And we're back with Paul Salamh for round two. Paul, 2 years ago, you came on the podcast for the first time chatting about shoulder special tests. We're still chatting about the shoulder, but we're talking about frozen shoulder. How have you been over the past 2 years? For people that haven't listened to that first episode, can you tell the people who you are and what you do?
Yeah, Chris, appreciate you having me on again. I'm surprised you asked me back after the first time, or maybe even the third time we met. So, no, great to be back on this. I think what you're doing is awesome. And yeah, so shoulder, that's kind of what I like to talk about. So that podcast we did a few years ago was on special tests related to rotator cuff related shoulder pain. I think that got a good bit of traction. Maybe still not where we'd like it to be, but we're going to still keep fighting that good fight and trying to make inroads in that. And so, yeah, now I'm still interested in all things shoulder, but focusing a lot of my attention on frozen shoulder. So it's been interesting to unpack some of the nuances around that. I'm currently at Tufts School of Medicine at the DPT program in Phoenix as the director of research there, and still adjunct at UIndy. So still got my hands in all that. And anytime I get an opportunity to talk about the shoulder, I'm just probably going to talk too much. So you may have to stop me at some point.
Frozen shoulder, you recently were the primary author on a Delphi study out of, I think, Journal of Manual and Manipulative Therapy. The title, and we'll link it in the show notes, the title is An International Consensus on the Etiology, Risk Factors, Diagnosis, and Management for Individuals with Frozen Shoulder, a Delphi study. So the paper itself will discuss a lot of the topics, and we'll start with a what should be a relatively simple question, but may not have a real answer. What is frozen shoulder? Does it have a clear consensus on the definition of frozen shoulder?
Yeah, I mean, I think that's a great place to start. You could probably have hours long discussion on this from a lot of different viewpoints. I don't know that we have as good a handle on what the definition of frozen shoulder is as we'd like to. This is something that's been studied for over 100 years, and we're still trying to unpack things. So, when something gets the attention for that long of a time, it's for a reason, and it continues to evolve. And it's gone through the naming of various things. Most recently from adhesive capsulitis to frozen shoulder, and it gets called different things in different places. But to define it, I think is both difficult and easy, if you will. So easy to say, okay, a frozen shoulder is going to present, it's going to be stiff, it's going to be inflamed, it's going to limit range of motion, it's going to be painful. But then when you really try to uncover it, it becomes a little bit more challenging. And I think that's one of the things I love about looking further into frozen shoulder is that we may not know as much as we think we know. And so I'm always glad to dive in, particularly in this particular study with a group of intellectual juggernauts in this area. And so, the folks that were willing to participate in this and provide their feedback and their thoughts and ideas around this was huge. And so a huge debt of gratitude to those individuals involved in this and helping this come to fruition.
It seems like been kind of cycles back and forth between pushing for utilizing adhesive capsulitis as the main term and frozen shoulder. And I think most of the lay public thinks of it as frozen shoulder. In the research community, does it really matter? Is there much push either way?
Yeah, my preference is frozen shoulder because it may not always the adhesive capsulitis definition or name may not always capture it in its true form because there are different mechanisms for this occurring. I don't think it's not a hill I'm willing to die on like rotator cuff related shoulder pain compared to impingement or things like that. I think nomenclature is definitely important. I think it's important here too. And so if I were to lean one way or the other, frozen shoulder is certainly where I'd lean. It makes sense to us as clinicians, it makes sense to us as researchers, and it makes sense to the general public, and it makes sense for what we currently understand this condition to be.
When someone's coming in and they are having a stiff, painful shoulder, but they haven't gotten the diagnosis yet, what should clinicians be aware of or be thinking when they're going through a differential diagnosis to lean them towards the likelihood of frozen shoulder? And what are some of the other diagnoses or presentations they should be ruling in or out?
Yeah, you're hitting all the big questions right off the bat here. I love it in typical form, Chris. So I think that's probably, I don't want to say one of the biggest challenges, but certainly one of the first things we need to think about as clinicians, because currently frozen shoulder exists as a diagnosis of exclusion. Even if you look at the British Elbow and Shoulder and Surgery sort of guidelines for diagnosis and management of frozen shoulder, it is a diagnosis of exclusion, meaning that someone comes to you with a stiff, painful shoulder, you rule out all other things, and you're left with, okay, I've ruled these other things out. This must be frozen shoulder. But those other things are nothing to scoff at. Those other things are um, can be sinister pathologies, although rare. Can be sinister pathologies like osteosarcomas, avascular necrosis, and then you can back up a little bit. It could be fractures, could be a locked posterior dislocation, could be severe glenohumeral joint osteoarthritis. Any number of these things that clinically may present as a stiff and painful shoulder, we must do our due diligence, mainly through our subjective exam, to begin to sift through some of these potential differential diagnoses, as you mentioned, to get down to understanding that, okay, what we're dealing with here is, in fact, frozen shoulder. And some of that may not even come to light initially. It may take several weeks of, various forms of treatment or different things to say, okay, this isn't behaving like I would expect frozen shoulder to behave. Perhaps we need to investigate something else as a potential differential diagnosis. So, not always going to catch these things right off the bat, but hopefully you can, within good reason early on, begin to identify whether or not this is something musculoskeletal, and then kind of work down from there. So, you know, in thinking about this earlier this week on one of my runs, I was thinking, it just reemphasizes the importance of our fundamental skill set, our subjective comprehensive examination followed by our objective examination, and then determining all that in the context of what the patient looks like in front of us for that specific individual. And it's no different with frozen shoulder. And so, if you can't pass, shoot, and dribble, then good luck in a game situation, right? And so those fundamentals need to be on point. And it's no different here with frozen shoulder, because those fundamentals, that's the foundation we rely on during our exam to help us differentially diagnose those other things before we feel comfortable managing an individual with frozen shoulder.
And things that would be easy telltales of this likely is not frozen shoulder would be what? In my mind, it would be that it's rarely, if ever, an acute onset of a frozen shoulder. It's this kind of insidious gradual. So if someone's saying yesterday I had this onset after a car accident or a fall, etc., like to me that would likely be something else. What are some other things that would really maybe reduce your probability of a frozen shoulder?
Yeah, I think the number one thing is what you mentioned, right? So a quick onset trauma is the biggest thing. So if you look at some of the potential differential diagnoses, locked posterior dislocation, which oftentimes gets misdiagnosed as frozen shoulder, any type of fracture at the humeral head, those sort of things are going to be following a trauma. So, even if the initial X-ray doesn't identify, and I obviously with a humeral head fracture and things like that, that's pretty clearly identified on a radiograph. However, locked posterior dislocations may not always be, depending on the view and who's reading and looking for that light bulb sign, that's indicative of that locked posterior dislocation. So those things, I think, are maybe easily gleaned from your subjective when you hear the trauma, or it's a quick onset, very acute. As you mentioned, the frozen shoulder tends to come on slowly over time. Gradually, they begin to lose range of motion, increase pain, disrupts their sleep. And so, we think sometimes about sleep as being something that might cue us into something, non-musculoskeletal, but we now know that a lot of musculoskeletal conditions, including frozen shoulder, or, the sleep hygiene in frozen shoulder is horrible. It's one of the number one things that patients complain about. And so, I think, again, back to the fundamentals of things you would screen for from a red flag standpoint for non-musculoskeletal related pain, not as easy to pick up outside of trauma. So there is, a little bit of gray area here where, okay, I do a subjective examination. I don't hear trauma. It looks like, sounds like, feels like musculoskeletal. Let's go ahead and begin, treatment or management, whatever we see fit, but then it's not responding as such, right? And so this is where, in the point of this conversation, I think is where people begin to advocate for routine radiographs for individuals who come in with a suspicion of frozen shoulder because of some of these differential diagnoses, being some are sinister, in nature, and others are, well, my treatment for severe osteoarthritis of the glenohumeral joint is going to be different than it is for a frozen shoulder. So I'd really like to know that. Plus, there's some evidence with MRIs looking at certain measurements with frozen shoulder, and being able to definitively say, okay, we know this individual doesn't have these competing diagnoses that may masquerade as frozen shoulder. We get a radiograph and we feel comfortable with that. But then there's certainly, a fair amount of evidence that might refute that, that's been published recently, and certainly a discussion we had within our Delphi study.
You had mentioned earlier maybe not complete confidence within the initial evaluation that it is frozen shoulder, but that's kind of your primary thought process. But over the course of a few weeks, you said maybe it's not behaving as I would expect frozen shoulder to behave with treatment. What does that mean for you or to you?
So, I think about someone maybe in the early stages of frozen shoulder where the pain is greater than the stiffness. So it's a whole nother conversation about the classification schemes that are sort of out there for frozen shoulder. And my tendency is to lean towards this, proposed classification that Jeremy Lewis brought up, which I love Jeremy Lewis and everything about him. So it's easy for me to cling to those things, but it's is it more painful than stiff or more stiff than painful? And so let's say someone comes in and they're in those early stages where the pain is greater than the stiffness. Okay, well, we know those people tend to respond relatively well to a corticosteroid injection within the glenohumeral joint. Helps to calm things down. Maybe we begin with something that helps to modulate the pain a little bit, and then early gentle motion, but they don't respond well to that. There's no give, um, there's no improvement with that. Or if they're in the latter stages where the stiffness is greater than pain, and we start doing some mobilizations or uh, that sort of treatment, and followed by stretching and exercises, and they're not responding, and it becomes difficult because these individuals don't respond sort of day to day. Sometimes it takes even those who respond very well to management outside of surgery, it takes time for them to get better. But there's a point in time, I think, as clinicians, and a lot of it comes with experience, right? Experience treating this population, managing this population. When they don't start behaving in those different stages as you may have seen patients behave or respond, then you should start to begin to think, okay, am I truly dealing with frozen shoulder? It also gives you more time, which is something that a lot of clinicians, at least here in the States, lack because of productivity standards and so on and so forth. So that initial evaluation may not give you the time to truly delve into some of these things. And so after a few visits and some of these management strategies, you might begin to see more and more information from this patient that might help you to think, maybe this isn't truly frozen shoulder. And so again, this is that gray area where people who want to be safe and sort of rely on those radiographs to know that they're dealing with frozen shoulder and not have to make those hard decisions later on or pay as close attention later on. I'm grasping a little bit there, but you get the idea that they would feel more comfortable having a radiograph to rule those things out. But we also know that sometimes radiographs don't rule those things out either. And so, again, we have to rely on those fundamental characteristics, not just of our examination initially, but our continual examination as we begin to manage this patient through the course of their journey in the healthcare system with frozen shoulder.
That classification, if you want to call it that, that you mentioned Jeremy Lewis uses or maybe created, the more painful than stiff phases or phase, and then the more stiff than painful. Is that what you'd recommend clinicians discuss or think about themselves with frozen shoulder, as opposed to that kind of what painful frozen thawing that used to be described? Is that what you're alluding to, that this is maybe a more simplistic way to look at it and describe it?
I think so. I would certainly advocate for that classification, and not simply for ease of use, but because I think it's more inclusive of the different types of frozen shoulder and their um, journey, if you will. And so, not everybody goes through those freezing, frozen, thawing phases, or we look for, things that may be a little convoluted to differentiate that. Where I think when the patient's sitting in front of you, it's easy for them to tell you and for you to listen if your ears are open and your mouth's shut, to what they're saying. That okay, their shoulder is more painful than stiff, or their shoulder is more stiff than painful. That's a relatively um, easy classification to use. And additionally, I think not only would I advocate for it because it's easy to use, because that's a horrible reason to advocate for something clinically, with that being the only thing you're standing on, but I also think it does inform us for our management, right? It also helps us to determine what might be the best management strategy for these individuals at those certain times. And to be honest, during this Delphi, it was one of the things that I don't think we really came to consensus on, was that classification system, because you have clinicians who've utilized that freezing, frozen, thawing, and there's even different classifications. Maybe there's even a permafrost or something out there. But anyhow, it's more about, I think, sometimes clinicians being comfortable utilizing what they've utilized, whether it be for diagnosis, management, research related, that sort of thing. But for me, and again, it's just my opinion, I think that other classification, that painful more than stiff, or stiff more than painful, is the most appropriate currently.
The common age group that people think of with frozen shoulder and sex is this female in their 40s, 50s, 60s potentially, that is likely the person presenting with frozen shoulder. Is that age range accurate, and is it more female predominantly than male accurate as well?
Yeah, I think historically that's certainly what we figured, right? Is this sort of middle-aged white woman is sort of the demographic that's most likely to develop frozen shoulder. And I think that may have been a product more of the population we were studying or have been studying across the years, than actually what may exist. And time will tell with that, right? It's the interesting thing about research. Unless you're associated with big data, which even has its own limitations, it's really hard to get a grasp on something this large that affects so many people. And so, within our Delphi, it was really the consensus from an age perspective was, someone over the age of 35, because many of us had seen individuals even that young, or in their 40s, or fifth, sixth decade of life, obviously having frozen shoulders. So it's not something we would, um, want to exclude from that age group. So I think the more we come to know about frozen shoulder, which is even still very little, the more we realize that the box we created for it initially may not be enough room to pack everything in, and so we need to think outside of that. And I think that's part of it, right? The gender it affects most, the age group, all those things. I don't know that we have really enough evidence to kind of point to a whole lot at that point in time right now.
For the objective exam, what are things that are common to find with frozen shoulder, and what are things that you may notice or see that if they do occur, it's probably less likely that it's frozen shoulder?
Yeah, I think the common things, obviously, is you've got a global loss of active and passive range of motion in that shoulder. Um, pain's probably going to be there. It just depends on to what level, right? But there's going to be that restriction, particularly at end range. The pain is going to be there in all directions. You're going to have decreased passive external rotation greater than um, than the other motions typically is a hallmark. If you look at all these kind of classification schemes or diagnosis schemes for frozen shoulder, that external rotation loss tends to be the biggest one, greater than others, including internal rotation. But internal rotation gets limited pretty big too, as well as abduction. And then another thing that the group kind of pointed to was that, not only limited external rotation when you're, testing in that, neutral position is 0 degrees of abduction, but as you increase that abduction, the external rotation becomes less and less. So right within their available abduction, as they try and externally rotate, it becomes less and less evident that they have that motion available. So I think those are your kind of, global loss of range of motion, passive and actively. And then what we look at passively tends to be what clinicians reach towards for a hallmark, of that. But then also things like, disrupted sleep hygiene that we talked about before. Individuals who, if they do sort of a quick uncontrolled movement, it becomes very painful, right? These people may over time have adapted to turning their body to reach for something slowly and within their range of motion that they have. But if they forget about that, or something emergent comes up and they need to grab something quickly, those type of motions may sort of flare that shoulder up, or cause them significantly more pain than they had at rest. So I think all those things are indicative of frozen shoulder. When I start hearing those things subjectively, when I see those things objectively on examination from a range of motion perspective, my spidey sense is tingling pretty well with regards to a potential frozen shoulder that I'm going to have to manage with this individual alongside me.
The location of pain and symptoms, where are people typically pointing? Where location wise do people tend to have symptoms?
Yeah, I mean, they typically, if you were to ask them, where is your pain? If you don't ask them to point, they're probably going to put their hand across their deltoid, right? So maybe the entire hand encompasses the shoulder, and you think as a clinician, well, that's not terribly useful. Yeah, I know your shoulder's bothering you, that's why you're here. But I think when we ask them more pointed questions, it's kind of in that upper arm area. Around the deltoid insertion is where I think most patients and clinicians and researchers would agree that, and particularly within our Delphi, that tends to be the location of pain for most individuals.
It's uncommon for them to be describing radiating or radicular symptoms down past the elbow, neck symptoms. That's not a typical presentation of frozen shoulder. They may have frozen shoulder and some other type of pathology, but frozen shoulder rarely has those type of either referred or radiating symptoms.
Agreed, right? Yeah, and as you mentioned, unless there's something else going on, I will say though that over time those compensatory mechanisms could lead to tight upper traps and things like that. So that neck pain that we would typically see with individuals coming to us with shoulder pain in general, that might be linked to compensatory mechanisms or increased tension in some of those muscles up there, that may not be truly in a cervical nature, but more of a musculoskeletal as a relationship to the shoulder not performing as they might like it, certainly. But yeah, I would say those other things are relatively rare. But if you do come across them and everything else matches up, I wouldn't necessarily exclude that as a possibility, because as you and I both know, conditions sometimes can coexist together, but rare. 100% agree.
In the Delphi study, you all discuss primary frozen shoulder and secondary frozen shoulder. Can you
Mhm.
discuss the differences between those two? And does treatment or overall prognosis change between the two?
Yeah, primary frozen shoulder is that idiopathic frozen shoulder, that classic frozen shoulder that someone comes to us, they didn't really have anything that happened. And we don't know why it's going on, which, it just baffles my mind that we have this, we call it idiopathic frozen shoulder. It's primary frozen shoulder, but we don't know why you have it. Um, so there's that. We can unpack that later if you want. So there's that primary idiopathic. We don't know why you're having it frozen shoulder. And then there's your secondary frozen shoulder, which depending on who you talk to and what you read, can be classified in different ways. I would say that the systemic, extrinsic and intrinsic subcategories are a good place to start. And that kind of gets to those things that would be, maybe somebody has a trauma and they're immobilized for a period of time. Maybe someone has, diabetes. Maybe they, have thyroid disease, or adrenal gland conditions, or a metabolic syndrome. Even hyperlipidemia and some other things are starting to look like they fit into one of these categories, that individuals are coming in to us with frozen shoulder. And then connective tissue disorders, obviously. And so I think, you know, as technology and medicine advances, right? So now we can do these studies and we can run assays and look at, genetic factors and things like that. You know, now we can look at those things among individuals with frozen shoulder and say, oh, all these people with frozen shoulder have this in common. We never realized that because we really never, had the, ability to look at that, or we never thought to look at those things among this population. So I think that is another area that requires continued exploration, to maybe unravel a little bit more of that idiopathic and understand better this, this secondary frozen shoulder, and gives us, a charge as clinicians to be more comprehensive in our care of individuals in general, to help, prevent, if you will, frozen shoulder from occurring, but also, helping to mitigate some of these, comorbidities, if you will, that exist commonly with frozen shoulder. Okay, we know that you have 3 of these things that go along with secondary frozen shoulder, but we're going to treat the frozen shoulder and not these 3 things that could be really closely related to frozen shoulder. It seems like we might be missing the mark there, as clinicians. But again, is it do we have the time? Is it within our scope of practice? Are we close enough with a team of interdisciplinary healthcare providers that we can, manage this patient's care holistically and not just as a musculoskeletal practitioner? And so it's interesting how, the more we find out, the more we realize that, wow, we can't exist in our silos and treat patients as best as they deserve to be treated. We actually need to work together. And so wouldn't that be a wonderful thing if one day that would happen? We all know it's the best thing for the patient, but the barriers tend to keep us from doing that, unfortunately.
You mentioned earlier the cortisone injection idea early on. For individuals that are within the first few weeks or months of frozen shoulder, what are the recommended treatment strategies or options?
Yeah, I think so. If I were to kind of take that a step further and say maybe those individuals who are more in that pain, more pain than stiffness category in those early stages, as you mentioned, right? So, you know, the other thing I just to this is at the forefront of my mind. Maybe everybody out there listening is probably smarter than me, but the first thing I think about is, just because someone comes to me with frozen shoulder initially doesn't mean that, they've just started having this. They may have had it for a very long time, and for whatever reasons have either dealt with it, had, hesitations or insurance, barriers to get in to see you. And so don't just assume, and I'm talking to myself here, and if anybody else wants to listen, don't just assume that just because someone's initially coming to see you for frozen shoulder in their first episode, that it's acute. Obviously, that's why we do the subjective. And so, but through that examination, if we understand from the patient that this has only been happening for a little while, and my pain is really my primary limitation. I'm obviously limited in these ranges of motion, but my primary impairment is this pain. And okay, folks tend to do really well with those corticosteroid injections, reduce that inflammation, allow them to move a little bit more, and get more mobility, and do more from a management standpoint. I think another huge thing that maybe we don't think of is, whoa, is it stretching? Is it non-thrust manipulations? Is it this type of exercise or that type of exercise? But information and advice and reassurance to this patient is huge in those early stages, right? They're being told, if they have primary frozen shoulder, we have no idea why you have this, but yeah, your shoulder is really painful and it's stiff and it's likely to go on for a while, and we're going to try and management through its course. We might be able to help, move that course timeline a little tighter, help you work through this a little sooner, manage through it. But, education to them, I think, is huge. And it's one of those things, it's certainly under, uh, explored in the research. Will King, a good colleague and friend of mine, and some other folks have looked at sort of more of the patient experience as they go through this journey with frozen shoulder. And man, a lot of them feel like they're left hanging out to dry. Like they just, they're kind of in this limbo, and reassurance and some understanding and a little bit of advice and education goes a long way. It has a huge impact on their pain and their feeling of self-worth, and has a big impact on their overall psychological health.
The cortisone injection, you mentioned kind of maybe dampening the inflammatory response. Is the pain in the early stages largely driven by inflammation? And is the cortisone injection, that's the main mechanism of why it's potentially helping? Or is that just a hypothesis?
Yeah, no, I think that's the idea, right? And I think that's why we see when individuals respond so well from a corticosteroid injection, I think those probably are the individuals who have, that primary idiopathic, not to say you can't have the inflammation with the other ones, for sure. I mean, there's that piece to it as well. And I think those individuals are going to respond really well for those reasons you just stated. However, there's this very real idea that maybe not everybody who is diagnosed with frozen shoulder truly has a capsular restriction. And so, could a cortisone injection still help those individuals who don't have a true capsular restriction? Well, potentially, right? If it's painful and inflamed, and you change the chemistry in that synovial fluid and around there, it might help to reduce the pain. But it gets to the bigger question of, does everybody who have frozen shoulder truly have a capsular restriction? And I think the answer is no. And I think that's something we're working on, a group of us and some other folks. And so I'm curious to see what that looks like, because then that influences everything we do going forward with regards to individuals with frozen shoulder.
I think frozen shoulder used to be thought of as a self limiting condition, meaning it's going to get better on its own, regardless of if treatment is provided or regardless of the treatment. Is that true?
Oh boy, yeah. I think that's a big question. I think there's a lot of answers to that, even though it might seem like there's only a few answers. Um, Frozen shoulder, I think, if you leave it alone long enough, will it get better? Yeah. Well, what's long enough? I mean, because people have been reported having this for several years, right? And dealing with this for several years. Um, and and then you have probably the most reported out there is that it's about a year. Some people will say it's about a year time frame. Maybe 6 to 8 months you'll deal with this. And so we just kind of do this, watchful waiting sort of thing, and just kind of see and let it unravel itself. And no need to intervene or get in its way of its natural course, its natural history. And I would say, I think we can do better than that. I don't know too many other conditions that we're comfortable saying, well, this will go away in about a year or two, or maybe 3 years. We're not sure, but if you just go home and deal with it, I think you'll be all right. I certainly wouldn't be comfortable with that as a patient, and as a clinician, I wouldn't be comfortable telling patients that. And I know there's some recent evidence out there that looks specifically at this with regards to physio, and the impact of physio when individuals with frozen shoulder and cost and things like that. I won't get too deep into that away from this question, but I think there are things that we can do to shorten that time frame and make that time that the individual is managing their frozen shoulder much more conducive to what it is they want to do, right? And a lot of that can be through education. A lot of it can be through reassurance. It can be through non-surgical interventions. But I think to say that where we are in our understanding of frozen shoulder, that best practice would be to watchfully wait and let it take care of ourselves itself, would be foolish.
Yeah, the reassurance that we've either through imaging or through just this in-depth discussion and examination that there's a really low likelihood chance that there's something more sinister going on. So reassuring them that this is what it is and what it means, that it will improve in time, but it does take a while. We have things that you still can do to stay active and to slowly improve some of the range of motion and maintain as much strength within the range as you can tolerate and train the rest of your body. You still have three limbs. if you have some symptoms during daily activities, you're not worsening your frozen shoulder, you're not creating more damage, providing reassurance that you can have some discomfort using that arm throughout the day. I think those are really powerful things that I've discussed with patients, and it provides some reassurance and relief and comfort knowing a variety of those things, but it still doesn't help in the short term with potentially like this still sucks in the short term. From an exercise or manual therapy or any treatment from a rehab perspective, is there a consensus on strategies or more specific interventions, or is it a pretty broad, some level of exercise locally at the shoulder is beneficial, some form of hands-on graded, manual therapy or improving range of motion is beneficial? How specific do these recommendations get, or are they pretty broad?
Well, Chris, everybody grabbed a pen and paper when you started, poetically spouting that out there to what you would say to a patient, because that was amazing, and I would hope that everybody listening would have kind of jotted down some notes from that, because that's what patients need to hear, right? That's the reassurance, that's the understanding, and that's awesome. So wow, I even took some notes while you were saying that. But so to your question, I don't know that we're in the granular level with regards to intervention strategies. I think what we currently know, certainly what reached consensus in this Delphi, which again is that, right? It's expert opinion, and we talk about how that may or may not relate to current best practice or evidence in the current literature. But for those individuals in that sort of stiffness greater than pain perspective, right? I think that's where we can really be more effective with some of the things that you mentioned, with what we would consider as, what physios can do to help manage frozen shoulder, manual therapy techniques, so, your non-thrust manipulations, depending on the grade, depending on the presentation, all that stuff, where their limitations are and how you're trying to restore that, followed by, some sort of active or engaging the patient in, if you increase the range of motion, from those interventions, then let's utilize that range of motion you gain through some sort of, stretching, whether that's passive, active, assistive, active that they can tolerate it, sort of adhering to the same guidelines with regards to pain and whatnot you'd be okay with individuals experiencing after some sort of stretching bout or exercise. Certainly isn't something that you want to piss off early in those stages where pain is greater than stiffness, or if it starts to shift in the other direction, that would also, as a clinician, would kind of cue me into maybe I'm starting some of these interventions a little too early. If I'm irritating this shoulder more than I am helping it, maybe I've stepped into this phase and my treatment strategies right now maybe a little prematurely, and I need to back up a little bit and manage this a little bit differently for a little longer before I try and do some of these other strategies. And so I think, in regards to the consensus from the Delphi, from my own personal experience and what I know from the evidence, I think what we can comfortably say is that, manual therapy, stretching, and some form of light exercise when appropriate with resistance, but that's later on down the road, is appropriate. But we're certainly not at the stage where we're saying, okay, well, these exercises of this variety tend to be the most beneficial for these individuals. And I'm always cautious when we get to that point, because for me, that oftentimes takes the patient a little bit more out of the picture than I would like. It goes back to the olden days where we'd pull out an index card for a diagnosis, and these are the interventions you're going to do. And golly, we've come a long way, hopefully. Then we know that, even if I have the same diagnosis and the same stage in this class, if the patient in front of me is different, which it is every time I see them, then my interventions and my strategy ought to be different. Otherwise, I'm not practicing true evidence-based medicine, which relies on those three pillars of the attitudes and beliefs and what the patient brings to you. Same for the clinician, and then the current evidence, and taking all that into consideration. Ignoring one is like ignoring the other. So, yeah. So again, I'm always hesitant when we get to too granular of a level for most things. I'm sure there's certain things where that may not hold true, but yeah.
Is there things now that used to be done commonly a few decades ago for managing frozen shoulder that within this Delphi study or more recent papers have just been kind of removed as primary treatment options? I know manipulations under anesthesia were maybe more common or more discussed years ago, or is something like that, or surgical options or other things that maybe are a little bit less recommended at this point?
I think that manipulations under anesthesia and capsular lysis, surgical interventions for this, for people who don't respond well or well enough for their liking, um, with frozen shoulder are still very prominent. I see it frequently, and I'm not sure I can kind of say definitively, should that be, good, bad, or ugly. I mean, if you look at our Delphi, one of the things that reached consensus in the latter stages was surgery, right? Because some individuals just don't respond to conservative treatment, and surgery meaning, maybe that's manipulation under anesthesia or maybe that's capsular lysis. But I've also seen folks who've had manipulation under anesthesia and they come out and they're more painful and guarded than they were before they had the manipulation under anesthesia for different reasons. And I've also seen people who respond really well. I think the challenge is identifying the appropriate patient, right? And I think that gets back to, early on having that shared decision-making conversation with the individual, proposing all potential options, including no treatment, what the current evidence suggests, what your experience is, and then ultimately letting the patient decide. And so sometimes, ultimately, the patient will decide that they're not going to get better with something that isn't surgery. And sometimes that's the way it plays out. And so I think surgery has a place, but I think we need to be careful about how quickly we jump to something like that and give other options a chance before making that recommendation or having that conversation with the patient for sure.
With the patient that's coming in the more painful stage, they're maybe a few months in. This can take quite a while. Like you said, depending on the person you talk to and each patient, maybe a year on average, or a little over, a little under. Knowing that it's a long recovery, do you believe that rehab providers should see patients throughout the entire course of their rehab? Do you think that it should be just infrequent check-ins once there's an understanding and confidence of how they can perform activities at the house? What do you think rehab should look like throughout the course of care?
Wow, yeah, that's a big one. I think early on we should be mindful. Well, always we should be mindful of you know the burden we place on both the patient and the healthcare system from the standpoint of our and the effectiveness of what we can actually do during those stages. I think sometimes we become a little overzealous in any profession that, if you come in and your car's not running right, then I'm a mechanic. I'm going to find something to work on in your car, right? Or sometimes I think as physios, we can take anybody who comes to us and find something that we think we can work on them with. But do you really need to see them 2 to 3 times a week, every week to help manage frozen shoulder in the early stages? I don't think so. I think that's a more appropriate time for some of that reassurance, for the education, right? But then you have to be mindful of not losing that patient in their healthcare journey either, right? So you have to be, that's the art of our profession, right? So there's the science and the art. And so I think that's where the art comes in, and the building that rapport early on with that patient, because the last thing that you would probably, not the last thing, but one of the last things you'd want to hear as a patient is, well, this is going to go on for a while. We don't know what's going on. I don't know what to do for you, so I'm not really going to see you that often. Check back in 2 months. They're going to leave there and not even remember you, your name, or how to get back to the clinic because they don't have any reason to, right? What did you provide them? You provided them nothing. And so if they come to you, they're in these early stages, you educate them about the condition, you provide some reassurance, you provide them with information, basically pull out the script of what you said a while ago, right? You provide them all that waxing poetically information, and then say, hey, you know what? I'd like you to check in a couple weeks. I want to see where you're at. In the meantime, do X, Y, and Z as you can tolerate, and let's see how you do with that. If it gets worse, maybe check back in sooner. Or, and it's going to differ for every patient that sees you, depending on, their current activity level, what it is they want to do, what stage they are in their life and what stage they are in frozen shoulder. all these factors. And that, again, is the art of taking all that information. You can have the same objective examination for a patient and diagnose them with frozen shoulder. They can have the same measurements, the same everything, but you're going to treat them all differently because you're treating that objective information in the context of the subjective, meaning you're treating it in the context of the individual that sits in front of you, who comes to you vulnerable, in pain, not being able to do what they want to do, and they're looking for your help. And for a lot of people, it's not easy for them to take that step. And so to provide them that reassurance and that safe place to have those conversations and to give them something definitive is valuable. But I also think it's not appropriate to take advantage of the patient at a point in time like that, intentionally or unintentionally, and say, I want to see you 3 times a week in here just to kind of monitor this at the early stages, when we have no evidence in all three of those pillars to support the rationale for that burden on the patient. And so I think we need to be mindful of how we navigate through this, and what it is we're going to be effective at doing in these different stages. And that's part of why I'm so interested in continuing to study this further and unpack this, is that we don't know as much as I'd like to know with regards to this. And I think anybody who spends some time in frozen shoulder would tell you that. And so I'm keen to keep going here, even though I probably won't answer maybe 2 questions in my lifetime if I'm lucky. At least maybe we're a little further along than where we were 10 years ago.
They've fully recovered or they're near full resolution of symptoms. What is the likelihood of someone having another recurrence or incidence on that side or on the other shoulder? Is there data to show these averages?
Oh, unfortunately, it's not uncommon for someone to see it on their contralateral side. I would say it's probably more common for them to see it on the contralateral side than to have a second occurrence of frozen shoulder on that side. And again, the literature on that is so kind of spotty. I don't think we really have a good handle on that, but it is something that we know is not terribly uncommon in individuals to have a reoccurrence of frozen shoulder on the other side. Now, I don't want to say there's good to be had from that, but if you successfully helped a patient navigate through their management of their initial frozen shoulder and they start to see this again, my sense is most folks would be keen to pick this up sooner rather than later, right? So self-identify, oh my goodness, this seems a lot like what I was dealing with before. So they're preemptive, they identify it earlier, they've had a great outcome with you, so they get in touch with you, they come back to see you, and you kind of reiterate some of the things. Hey, you know what? You've been through this before. You've gotten through it. We're going to kind of manage this the same way, but maybe now, maybe I don't need to hold your hand as much through this process because you've been through it before. What do you think would be the best way to manage this second episode of frozen shoulder? And then let them tell you what they feel comfortable with. They might say, well, I just came in because I wanted some reassurance that this is what's going on, but I feel comfortable for this period of time dealing with it on my own because I've been through it and I know what to expect. It's not the end of the world. I know how to adapt. I might check in so often and so on and so on. So I think there's a light at the end of the tunnel a little sooner for those individuals, obviously, if treated appropriately in that scenario.
I think that also goes for a lot of MSK conditions where there can be a recurrence with that specific, limb or on the other side. And if you've done a sufficient job during that initial course of care, developing all those things that you've discussed, it still is frustrating and sucks for it to occur again or occur on the other side. But they should be hopefully in a much better headspace and confidence of, I know at least some strategies and at least I have this provider that I can go to confirm that it's potentially what I think it is. But this may be an easier thing to swallow the second time because I've already been through it once.
Yeah, that's huge, right? I mean that's healthcare. That's I think that reliance, and well, actually this is life, right? I mean, if you've had a good experience with someone in some even consumer world, you're more likely to recommend or go back or feel comfortable about that than if you had a bad experience, or you weren't treated well or something along those lines.
Paul, is there anything else that you feel like we should touch on or discuss before we finally wrap it up?
Knowing that we both have other things to do in the day, Chris, I'm gonna refrain from talking about all the other things I want to talk about related to frozen shoulder. But man, you've hit on, I think, all the huge pieces, and provided the listeners with some great advice in management through both your questioning and through talking about how you would speak to individuals coming to you with frozen shoulder. I think that's just gold for folks out there who see people with frozen shoulder. What Chris talked about through here. So yeah, I appreciate the time.
Yeah, thank you, Paul. I remember, quick story. The one of the first patients I ever had in my first ever clinical rotation in PT school, individual came in with frozen shoulder. And this goes to one of your points earlier on. I was a little too uh excited about loading them early on. And I got her doing, I think it was only 2 or 3 pounds of a flat dumbbell press through the range of motion she can tolerate. She came in a few days later, extremely flared up. And it was like, okay, could that have occurred with potentially even a more conservative activity? And was that even that aggressive? No, but it was one of those things where even though I feel confident that if there's a spike in symptoms, she's not worsening her frozen shoulder, but it showed that having a better scale of maybe where someone starts and what they were doing previous to physical therapy was just a great uh, experience, even though it kind of sucked for the patient and for myself, that there's strategies to maybe start at a more conservative place, and that frozen shoulder is also pretty volatile during certain periods. But I remember that patient because that was probably my first week or second week of my first ever clinical rotation, and it set the tone for other frozen shoulders in general. But it's a tricky diagnosis to manage as a clinician and as a patient for so many different reasons. But I think having these conversations with people like yourself, and with also reading these papers and just getting reps and exposure to patients, it makes it a little bit easier as a clinician to manage these scenarios.
Yeah, no, I think that's a great point. It's funny you remember that, right? The things we remember as clinicians early on in our career, and rarely are we right on the mark with interventions, reps, sets, endurance, fatigue, that sort of stuff with patients, right? It's kind of a trial and error sort of piece, and that margin may be a little wider with frozen shoulder, if we as we talked about. So, as clinicians, give yourself some grace out there, and give yourself some time to develop, and always find a mentor, no matter how far along you are in your career or what it is you're doing. There's nothing to substitute a good mentor.
100%. Okay, Paul, we'll call it there. Thanks again.
You got it, bud. Thank you, Chris.